Thank you very much. Um, uh, Thank you very much for the invitation, and I kind of really flattered to be considered in the same group of individuals that you've had talk to you about stem cell research and biology already. I'm really a clinician by training, and so this talk is going to be a lot about our clinical experience. And so the subtitle, Lessons I Learned from 20 Years of Experience. I've been doing this since we did our first transplant for autoimmune diseases in the late 90s. And so have accumulated about 180 patients over the years, and have been able to get samples from some of them, and others understand their clinical course, and use that to both understand autoimmune diseases and this whole idea of remodeling or regenerating an immune system that becomes self-tolerant. So I don't have any financial disclosures, and everything that I might talk about is off-label. Everything is unique, pretty much. So there are two ways to treat autoimmune diseases. The standard way, which is using disease-modifying drugs, or usually result in long-term immunosuppression. You have to keep giving them to kind of just keep the lid on the immune system to prevent it from breaking through and attacking different tissues in the patient. And I kind of find this akin to flying an airplane. So you need to provide fuel for the whole course of the flight for the airplane from the start to the finish. And so it's the same with the immune suppression. If you stop it, well, then the disease is going to come back. Autologous transplant has a different kind of paradigm. Rather than just suppressing the immune system, we're going to try to use autologous transplant to get rid of the autoreactive parts, the parts that are causing the problem, and allow a new immune system to regenerate. And that regenerated immune system has better behavior. And it's a one-time treatment. It's more like the space shuttle, where you have a huge expenditure of fuel at the beginning, but once you've taken off, it goes forever without having to refuel again. And so it's with this second paradigm that I've been interested in probing how that actually can be used to benefit patients, but also why it works. And the reason being, if we understand how it works, well, rather than just clobbering the immune system and getting rid of the whole thing and putting back stem cells to grow a new one, maybe we can more finely dissect the immune system and have less toxicity associated with this procedure. We've, as I mentioned, started our first transplant in 1999. We've seen generally more transplants every year since then. Now we're doing about 20 to 25 transplants a year. The sole exception has been 1 year where this was the COVID year, where we had to cut back on our hospitalizations. And we've had an interesting course. So while initially our transplant started and we were going to target treating rheumatoid arthritis, competing technology came along, the disease modifying agents, and we stopped seeing patients with rheumatoid arthritis. But my neurology colleagues were there, and they did not have good therapeutics for their patients. And so they started to send patients with other diseases, multiple sclerosis and myasthenia. And our rheumatologic colleagues, while they had an answer to treat rheumatoid arthritis, did not have answers to treat other rheumatologic diseases like scleroderma. And what we found over time is that as we gained experience with one disease and with one specialty group, they would start finding other patients that had autoimmune diseases that were maybe more unique and refractory to current technologies, and they would send them with the question of, well, does transplant work for those patients? And so from these early times where we had a few diseases, we've over time been able to treat patients with Crohn's disease, another rare autoimmune encephalitis called stiff person syndrome, peripheral neurologic disease called CIDP, a neuromyelitis optica, again, another antibody-driven autoimmune encephalitis. And then the neurologist started to send patients with problems that they couldn't put a name on, but that they could identify the process as being autoimmune. And so we've seen some non-syndromic kind of autoimmune diseases as well. And so the lesson that I've learned is if you build a technology, other people around you will start thinking about novel ways of using your technology to better patient care. For those who are not familiar with a stem cell transplant, we kind of have three phases. So we have the phase where we mobilize hematopoietic stem cells from the bone marrow into the peripheral blood, where we can collect them and then process them to purify them. We have the phase where they undergo a transplant conditioning to destroy the autoreactive immune system in the patient. And then finally, we have the last phase where we transplant back hematopoietic stem cells to regenerate the marrow, the blood, the immune system, and where we support the patient through the toxicities of the chemotherapy that we use. Just to look, well, do we actually get rid of the immune system? And I'm going to talk about a couple different groups of patients here, because over time we've had different focus in our research, and so the samples come from different groups. We did a few patients that had a problem called sclerosing cholangitis or primary sclerosing cholangitis, where the immune response is against the bile ducts in the liver. And we transplanted those patients, but before and after the transplant, we were able to collect blood samples and do deep T cell receptor sequencing. And we could look for clones that were present beforehand in the samples that we pulled from the patients after the transplant. And we found that most of the commonly abundant clones that were present before the transplant disappeared. And so the chemotherapy can get rid of the immune system, at least with the highly abundant clones. We also can demonstrate using our MS patients that we get rid of their antigen-specific, we get rid of T cells in an antigen-specific way as well. And so before the transplant, we could measure the presence of anti-tetanus toxin, toxoid T cell immune responses, and these disappear after the transplant. When we measured at 6, 12, and 18 months, we then re-immunized the patients, and that reactivity reappeared. Wasn't so clear with myelin basic protein, where we saw the reactivity beforehand, and it certainly almost disappeared after the transplant. But over time, there seemed to be an increase in anti-myelin basic protein. And so different antigen systems may respond differently to the transplant chemotherapy. And I'll come back to this in a few more slides. And we can show that this happens specifically to the IL-17 producing T cell clones, the ones that have been implicated in autoimmunity, that they tend to disappear before or after the transplant, after the chemotherapy. It's not this elimination of immunity and immune cells is not limited to just cellular immune responses, but we could also show depletion of antibodies that exist in the patient. And so colleague Andrei Kruzinski spots a number of different liver antigens on a slide, and then probes the slide with serum from a patient, either before or after transplant, and then uses a secondary IgG or IgM antibody to look at the reactivity. And you can see that after the transplant, many of the antibodies that were seen beforehand have disappeared. And we can quantitate that and show that that kind of change in each of the clones is stable over time. They don't grow back, so to speak. And so the chemotherapy can get rid of humoral and cellular immunity. We then have to deal with the graft. When we collect hematopoietic stem cell grafts, they're actually a mixture of leukocytes, and about 1 to 3% of the cells are actually CD34 expressing hematopoietic stem and precursor cells. And so we use an immunomagnetic selection procedure to purify away the immune cells and leave us with purified hematopoietic stem cells. And the reason we do that is more theoretical. We don't want to put back, potentially retransplant back autoreactive immune cells that then can undergo homeostatic expansion in the patient. And just a visual representation, these are individual patients here. The pink represents the amount of hematopoietic stem and precursor cells that express CD34. You can see they're a very small proportion of the grafts before selection, but after selection, almost all of the cells in the graft are CD34 expressing. So when we put them back, we can follow then the immune reconstitution, and we can look at the beginning at thymopoiesis, and we can see that we get rid of thymic function for a period of time, but after we put the stem cells back, this recovers to an appropriate age and match control, which is this gray line here, within about a year after the transplant. However, if we look at peripheral blood counts, we see that there's never a full recovery of the number of circulating cells in these patients. So CD4 cells before the transplant are around 0.5 times 10 to the 9th. After the transplant, the CD4 cell count remains very low for 2-3 years afterwards. And we could see this in the subpopulations like effector memory or central memory or naive cells. And we see a similar sort of thing in CD19 cells and in CD8 cells. And so there's something that, while thymopoiesis is normal, the growth of the cells and their survival in the circulation is not. And yet our patients never develop opportunistic infections. And so while the kinetics of the immune system are altered, the dynamics that keep the patient protected against pathogens seem to be functioning normal. Remember a couple slides back, I said that we get rid of many of the autoreactive clones. Well, we can look at the clones that exist after the transplant and compare them to beforehand, and not all the clones disappear. Many of the common clones disappear, but there are rare clones that seem to persist after the transplant. And if we look at these clones that were present before and are expanded after the transplant, most of these are CD8 cells, so effector cells, while many of the new clones that develop are CD4 cells, so regulatory cells. And so I think this was an observation that we saw in 2 patients that we did a transplants on, and we need to investigate this further. I think this is telling us something profound about the way that immune reconstitution occurs, and that the regulatory cells that come back are more important than getting rid of autoreactive effector cells. There's a couple more lines of evidence that would support that. And so while we see a reduction in Th17 cells, as I mentioned, after the transplant, the cells that are autoreactive that come back tend to be skewed towards Th1. And so they're not, the cells that were autoreactive before and autoreactive after are not the same cells. And so somehow that recurrence of autoreactivity occurs in a different way because the cells make a different fate decision, becoming a more benign kind of Th1 phenotype. We also know that there's some heterogeneity in autoreactivity on the humoral side. And so we did transplants for myasthenia gravis, which is an autoimmune disease directed against the neuromuscular junction. And many times these patients have antibodies to acetylcholine receptor. And so we did transplants, and we had 2 patients that were autoantibody positive before the transplant and remained autoantibody after the transplant, in spite of being in complete remission. And I think this indicates that the tests that we're using to measure the autoantibodies, we're measuring a polyclonal population of autoantibodies, some of which are pathogenic, some of which are just there. And yet the immune system, when it regenerates after the transplant, has been able to get rid of the pathogenic autoantibodies, the ones that are causing the myasthenia, but other autoantibodies that don't have that kind of propensity may return after the transplant, or may persist after the transplant, but not cause any disease. The idea of increased regulatory cells is shown here. We see both an increase in the number of regulatory CD3s, Tregs after the transplant compared to before, and we also see an increase in transitional B cell cells afterwards, which are other cells that have regulatory properties. And so kind of all these pieces of the puzzle are fitting together and kind of suggesting that what we're really doing when we do the transplant is wiping out the pathogenic clones and allowing the immune system to regrow. And when it regrows initially with a regulatory propensity, and then the body might develop autoreactive cells that leak through the thymic selection, but that are controlled by these newly developed regulatory cells. And that seems to set the patient on the right course. There's one part of this whole immunology that I don't really understand. And so we've been looking at the incidence of thyroid disease, and most transplant patients don't get autoimmune thyroid disease if you do a transplant for, let's say, lymphoma or leukemia. But patients who've had transplants for autoimmune diseases have a high propensity of developing a second autoimmune disease, most often thyroid disease. And if you look at our statistics, about 25% of our patients will develop thyroid disease after the transplant, permanent thyroid disease. And most of that is autoimmune. And so we have a clue here that something is going on, that these patients have a propensity for autoimmunity. We can control autoimmunity of some diseases, but it's in ways that we don't understand. There's still leakage of autoimmunity that develops after the transplant, and how that fits into the bigger picture, I'm not entirely sure yet. So just to summarize, stem cell transplant does not eliminate all pre-existing disease or pre-existing immunity. This is quite different than how we conceptualized transplant at the beginning. That autoreactive immunity, both at the cellular and humoral level, can reappear following transplant, but it's not the same epitopes that are recognized as prior to the stem cell transplant. That there are complex kinetics of reconstitution with this skew towards regulatory immunity, and that the full understanding of the reconstitution is still elusive. And this would fit with not understanding why patients get the secondary autoimmune diseases. I kind of have to put it into a model. I would say that before the transplant, patients have immunogenetics that are such that when a naive T cell sees an auto epitope, it tends towards activation and production of Th17 cells. And what we've done after the transplant is somehow compensate for that immunogenetic predisposition in such a way that the cells are less likely to activate. And if they do activate, they'll become Th1 cells rather than Th2 cells. And that may be something to do with the strength of the signal that they receive, and that they more likely will undergo spontaneous apoptosis or activation-induced cell death or regulatory control, so that you see lower levels of autoimmune, circulating T cells, but you also don't see the autoimmunity develop. Now, I just want to maybe switch to some of the clinical lessons that I've learned over the years. And so one is that we can stop ongoing autoimmune tissue destruction doing these transplants. And secondly, that organs that we didn't think would repair themselves can repair themselves, and so patients can actually get better. A colleague of mine looked in our MS patients and was able to measure serum neurofilament light chains, a marker of destruction of neural tissue, central nervous tissue. You can measure them in the serum, and before the transplant, patients with MS have very high levels of the production of neurofilaments because they're actively destroying tissue in their brain. Immediately after the transplant, our chemotherapy does additional damage, and so the level of neurofilaments goes up. But over time, as the autoimmune process and the chemotherapy damage wear off, the neurofilaments return to the level of about controls. And so the whole process is really another indicator that we can stop damage. In a very careful study of 24 patients with multiple sclerosis, we looked at the number of disease activity markers before and after transplant. And so this is just a graphical representation. Each line represents an individual patient. The line starts at the time of diagnosis and ends at the last follow-up. They're all lined up at the time of the transplant. The inverted triangles are clinical relapses or acute events that the patient had. And the little ticks is when their damage is such that they have a disability where it would be obvious to a hematologist like me. It's a significant and visible disability, like not walking quite right or having some other bowel or bladder trouble. You can see that before the transplant, there are lots of these inverted triangles, lots of relapses, but not any afterwards. And so the transplant is able to shut down the autoreactivity in these patients. And to express it in another way, these 24 patients had 146 patient years of risk before their transplants, 167 relapses for about 1.25 relapses per patient per year. But afterwards, with a longer follow-up period, they had 0 relapses or 0 relapses per patient per year. So clear difference in disease control before and after the transplant. And we confirmed this by looking at active scans, active MRI scans. So we would look for scans with new lesions compared to the previous one, or with gadolinium enhancing lesions, which indicate immune activation and damage to the central nervous system. And again, we see a number of positive scans beforehand in all our patients. Each inverted tick is a scan that doesn't have any activity. And so again, this matches our clinical experience. And we can look at this as well on an extended set, because we've done almost 60 additional patients after the study ended. And we see the same sort of thing. Before the transplant, these were patients that had a lot of relapse activity, but after the transplant, we've not had a relapse in any of these patients. Before the transplant, there was a lot of MRI activity, but very little afterwards. And the 2 scans were positive were the first ones after the transplant. And so some of the risk period would have been prior to transplant. So by changing the immune system, we can make a positive impact on acute inflammatory active immunologic diseases. And I've shown that for MS, but it also works for other diseases. And so if you look at the types of diseases that come to our clinic, many of the patients have multiple sclerosis, but we see other neurologic diseases, neuromyelitis optica, stiff person syndrome, myasthenia gravis, CIDP, and rheumatologic diseases, rheumatoid arthritis, scleroderma, dermatomyositis, and gastrointestinal inflammatory diseases like Crohn's disease. And while most of our MS patients do very well, and many of these other patients do very well, not every disease has as high a response rate as multiple sclerosis or myasthenia gravis, for that matter. And what I wonder is if this is telling us that maybe we're not classifying the disease or categorizing autoimmune diseases correctly. So right now, if you have an autoimmune disease, you go to the physician whose tissue is being damaged. If you have autoimmune thyroid disease, you go to an endocrinologist. If you have autoimmune joint swelling, you go to a rheumatologist. If you have autoimmune colitis, you go to a gastroenterologist. But maybe that's not the way we should be classifying these diseases, and rather we should be classifying them on the immunopathology, and that maybe some patients with rheumatoid arthritis and Crohn's disease have more in common with each other than patients with different immunopathologies based on that both have rheumatoid arthritis, for instance. And by looking at how patients or how diseases respond to different immunologic therapies, maybe we can start pulling that apart and understanding the predominant immunopathology for individual patients, and then we can direct their treatment properly. That's kind of a goal of where I see this work going and needing a bigger database of autoimmune diseases to be able to accomplish that. The last part was, I want to say, is a lesson that was surprising. And so this was, so when I was training, everybody told me, okay, when the brain gets damaged, no one ever gets better. You have a stroke, you don't get better. You have MS that's damaged your brain, you don't get better from disabilities. And so we went into doing transplants for patients with MS thinking and telling them, well, we're hoping that the best we can do is stop you from having worsening of your disabilities. And we got a few patients into our trial, and what happened is that they started to come back to us and tell us, oh, well, I can do this now, and I couldn't do this before, or I could do this, I can walk better, or I don't need my cane anymore. And so we started to collate that, and about 40% of our patients with MS had sustained improvement in pre-existing long-standing disabilities after their transplant. And we looked and so just to give you a brief breakdown, we can measure disability using a score called the EDSS, which mainly at the higher end, it's a score between 1 and 10, and 0 means you're perfectly normal, 10 means you died of the disease. And as you get a higher score, you're more disabled. But we could look at these subscores that make up the EDSS that are involved with different parts of the neural axis and different functions. And so some patients, the EDSS got better, that's after the transplant, shown in red. Some, the EDSS stayed the same, shown in yellow, and some actually deteriorated, shown in green. But you can see from the rest of these heat maps that different parts of the brain, the nervous system, recovered differently. And that even patients where their global disability remained the same, there were areas of their disability that improved. And even patients who tended to get deterioration in their EDSS because their walking deteriorated had improvement in, for instance, vision or cerebellar function. And so whatever is going on in the brain, whether it's because of our stem cells or because stopping damage and allowing regeneration of endogenous regeneration pathways come out, there's a spatial and temporal localization of this that benefits patients. We also saw this in other organ systems. So remember I said we did transplants for patients with sclerosing cholangitis. They have an acute inflammatory reaction around their bile ducts, and that ultimately leads to scarring. The blue on this is a stain that looks at fibrosis. And yet after the transplant, we can see the absence of these lymphoid infiltrates in the liver around the bile ducts, and a reduction in the scarring. And so if you stop the liver from being damaged by the immune system, then scarring goes away. and this is probably the one that surprised me the most, is in scleroderma, which is a scarring disease of the skin, which can sometimes cause depigmentation called vitiligo. We did this transplant on a young woman, and her vitiligo 6 weeks after the transplant completely disappeared, meaning that the skin has remodeled in that time. And so clearly there are organ systems that we think are affected by cell death or fibrosis that we think are fairly permanent, but maybe they're not. And these are more dynamic processes, so that if we intervene early before the fibrosis gets really fixed, we'll see improvement in patients. The last lesson I want to talk about is well, the barrier to doing this. So I've showed you transplant works really well. I showed you that we can get recovery in ways that we didn't expect after transplant. Why aren't we doing this for more people? And that's because of the risks. And so, for instance, in our cohort of patients with myasthenia, we see these different late complications. We see late autoimmune diseases like thyroid disease or immune thrombocytopenic purpura, but we also see late deaths like colon cancer, obesity at very long time points after the treatment. And we've had now a couple of our early MS patients die sudden cardiac deaths 25 years, 20 years, 25 years after their transplant. And so it's the short-term toxicity and the risk of chemotherapy-induced side effects, as well as infections early on, and the late risks of premature diseases of aging like cancer and heart disease that make us judicious in who we apply this treatment to. And so whoever has come to our attention has to have severe enough disease to warrant these kind of side effects. And so one of the things we need to do is make these transplants less toxic. So I just want to summarize, eliminating the immune system and regenerating a naive immune system can halt destructive autoimmunity in autoimmune diseases. And in the absence of this autoreactivity, you can see recovery from immune damage done before. And that we can use this for many different types of aggressive autoimmune diseases, often refractory to conventional treatment. There are a number of unanswered questions. And so is there a way to develop this tolerogenic state with less toxicity and risk? Can we understand what processes mediate repair and why some patients recover? And can we somehow use the immune system changes to give us an indicator about which diseases might respond better? And finally, I just want to acknowledge that I've worked in this field for 25 years now. I really owe everything to the dedicated patients and their families, particularly the ones early on where we only knew the risks. We didn't know whether we would benefit them, and they were brave enough to go through these transplants. But I also have to thank my many colleagues and collaborators who have helped me with this work, and the students, residents, and fellows who work on our transplant program, as well as the staff, the nurses, physiotherapists, pharmacists who work in our transplant unit, and the staff of the Canadian Blood Services Stem Cell Laboratory, where they do all our graft processing and cryopreservation. And then finally, the funding agencies who've helped fund parts of this, different parts of this work. Thank you.
Thank you very much, Dr. Atkins. So we have few questions. I can moderate them for you. So we have one question from Dr. Sunil Kumar. He says, can we use this technology for malaria treatment? Can we?
I don't think that it would be very effective for malaria. And just because the patients are immune suppressed for a period of about a year. And I would worry that they would, the malaria would become out of control during that time.
Then we have a following question from an anonymous attendee. She asked, did you see any difference in response to treatment between patients with cyclophosphamide pre-treatment versus patients who were irradiated?
Yeah, so in our MS patients, we always have used a chemotherapy-based conditioning regimen. And that was based on initially it was based on the fact that it was easier to schedule because we didn't have to find time on the radiation machines. It turned out in parallel early on, some groups were using radiation-based conditioning regimens to treat their patients and treat their MS patients. And those patients didn't do very well. They didn't show the recovery that we've seen, and they didn't see the halting of progression. And it's probably because of the neurotoxic effects of the total body radiation. And so there are some diseases where radiation may be effective and useful. So we've since started to use radiation in scleroderma. And we think that's better than using just cyclophosphamide because the high doses of cyclophosphamide we were using were causing cardiac damage. And so we can reduce the dose of cyclo and use a little bit of radiation and not see toxicity in that population, in the scleroderma population. And so I guess that it's a convoluted way of saying that the recipes that we use have to be selected for the disease and the patient that we're treating. And even in MS, we're starting to stratify our patients for their type of disease. If they have mainly damage to their brain or mainly damage to their spinal cord, whether we'll use cyclophosphamide and busulfan or cyclophosphamide alone. And so those are, again, on the clinical end, things we're just starting to learn and think about.
Pooja, you have Sagarika online also. She has raised her hand. Could you give her permission to directly ask the question?
Yeah, she can.
Sagarika, can you unmute yourself and ask your question? Sagarika? Okay. I don't know.
Because there's some network error, I guess.
Yeah. In the meanwhile, Dr. Atkins, I have a question. There was an interesting point you made that, for the autoimmune diseases of different organs, people approach different specialities related to that organ. So I was wondering that what could be the approach going forward? For example, the increase in COPD lately, and because organs function differently, is it the cell types which are getting affected? Therefore, the commonality, where does these things merge or diverge from organ to organ?
Yeah, I think as we're able to more finely dissect the immune system, we'll be able to see, certain autoimmune diseases, for instance, are mainly driven by a T cell subpopulation. And so those diseases, whether they attack the joints or the nerve endings, would benefit from a therapy that is directed against T cells, something like cyclosporin or tacrolimus, whereas other diseases might have a strong complement fixing antibody that causes the damage, in which case, an anti-complement monoclonal or an anti-complement inhibitor might be a better treatment for that patient. And I don't think we have a granular enough understanding of how the pieces of the immune system fit together in the normal immune response, let alone in these diseases, to be able to do that yet. But I think there would be benefit in how we approach people, because if we did understand that, well, then rather than saying, oh, you have rheumatoid arthritis, we're going to try this first, and if it doesn't work, we'll try this and this and this and this, we'll be able to say, oh, you have T-cell mediated rheumatoid arthritis. This is the drug you need, not this drug. And we'll get better response rates. That's kind of my goal, or my I guess, dream of things.
Nice. Sagarika,
Can you hear me?
Yes, we can.
Yeah. Good evening. So I just wanted to know about rheumatoid arthritis you said, and whether the same techniques can be.
Sorry, I missed.
Yeah, I think there is some technical error from her side, internet fluctuation.
Is that okay?
Yeah, now we can hear you.
Yeah.
So see, you have said that these techniques can be used in autoimmune disease like rheumatoid arthritis. So I just want to know whether the same thing can be used for osteoarthritis also. And if yes, then what is the difference between these two diseases to use this technique? Am I clear?
Yes. So we think of osteoarthritis more as a degenerative kind of problem, as opposed to an immune activation and the immune system causing the damage. And so I don't think that osteoarthritis would respond to this kind of technology. If I can just change the disease a little bit, though, I have colleagues who look after patients with Parkinson's disease.
Okay.
We think of Parkinson's as a degenerative disease of the basal of dopamine cells, and yet they're telling. Oops, sorry.
Yeah, okay. I'm sorry. Please continue.
They're telling me that there's autoreactive responses in Parkinson's disease, and so which came first? Was it destruction of the dopaminergic neurons that cause an autoreactive response, in which case getting rid of the autoreactivity in end-stage patients probably isn't going to make a difference. But if you could catch that early on, maybe you could prevent further damage. Versus is the autoimmunity early on the first thing, and that leads to the degeneration. And we've just always missed the autoreactivity in Parkinson's disease. And so there may be other diseases that we've classified as degenerative that still have autoreactive components to it, where we may be able to intervene with this kind of technology. I haven't taken up my colleagues' thoughts yet to be able to transplant a Parkinson's patient, but we debate that, and there's new work on Alzheimer's disease coming out as well, similar sort of thing, and so I think it needs more exploration at at a preclinical level before we would jump into humans with that.
Thank you, Professor. Actually, I really want more clarification in the technique to be used in RA also. That rheumatoid arthritis, like, you mean to say that only blood samples are more okay to do this, to do these experiments, or tissue sample is more okay? Hello.
Yeah, sorry. How we do the transplants in people?
Yeah.
So so we harvest. So the technique is very similar to, for instance, a stem cell transplant that would be used for treating leukemia or lymphoma, and so requires specialized centers to do this. We do the first step, we give chemotherapy, which destroys the circulating blood cells, so that stimulates stem cells to grow. And then we give a hormone called recombinant GCSF to augment that response, and it pushes the hematopoietic stem cells from the marrow into the circulation, where we can collect them by washing the blood through a centrifuge, essentially, and collecting the white cells. We process those and cryopreserve them, and then we take the patient when they've recovered and treat them with very high doses of chemotherapy and an antibody to human immune cells. So our patients often get 4 days of a drug called busulfan and 4 days of a drug called cyclophosphamide at maximal doses. So these doses, when they did the initial testing of them, the dose response curve would result in you know, if you pushed it any further, there was excess mortality. And so they're very high doses. They destroy the immune system. At the end of that period, we let the chemo drugs wear out, and we then bring the stem cells over and thaw them in a water bath and infuse them into a vein. And it takes about 2 weeks for us to see the blood cells grow from those transplanted stem cells. And during that time, well, actually it takes about 4 to 6 months for the patient to recover, with the first kind of 3 or 4 weeks being in hospital and daily attention to the patient to get through this kind of procedure.
Thank you, Professor. It's really nice. We will have more communication through mails. So wonderful. Thank you.
Thank you.
Any other questions from the audience who want to take it directly? Okay.
So I have a very general query. So it has been a long-standing tug of war between chemotherapies and stem cell transplants, and particularly HSCTs. So I was just wondering, so when we have pediatric HSCTs, so children of young age are already on the immunocompromised spectrum, or in case of immunity. So how do we take them for the therapies? Because do we have to wait for them to, like, keeping the selection biases in mind? So how do we, like, go ahead with the pediatric transplant processes and procedures?
Yeah, so there have been, I work at an adult only hospital, so I don't have much experience with children who have autoimmune diseases, but some of my colleagues in Europe have been particularly interested in juvenile rheumatoid arthritis and a few other autoimmune diseases that are more prevalent in children. And so they use very similar techniques to what we use in adults. Of course, they alter the doses because of the size of the child. They use similar sort of criteria, so they would select children where the more conventional treatments haven't worked, and the children are still affected by disease activity. But it's always a little bit harder. In one way, the children tend to recover more quickly from the effects of the chemotherapy, but on the other, you worry so much more because of it's a child, right?
Yeah.
Yeah. Thank you for sharing your views. Okay, other than that, I have a very naive question. It's out of the context. I read somewhere that you aspire to be an architect when you were young. So now that you see reconstituting people's immune system, how do you take it and you see the paradigm shift in the clinical approaches towards treatment strategies? So now that it's already 2022 and we have already seen a pandemic and so many more things, how do you look at it? I mean, what views do you have now?
So looking back over how this whole field has developed, it's been pretty interesting, and it would not have been my prediction when I went away to learn how to do stem cell transplants that I would deal almost entirely with patients with non-malignant diseases. But it works, and so if it works, you gain strength by understanding how it works, and so it drives you to keep doing this. I'm also interested in I like shiny new technology, and I'm really interested in how gene therapy can be melded with hematopoietic stem cell transplant, and particularly using gene therapy for treating sickle cell disease or thalassemia, probably some of the immunodeficiencies. And I'm hoping that before my career ends that I'll be able to do some of these things as well, and be part of that next wave of developing therapeutics. There's so many interesting things going on in science, and melding it with medicine to the benefit of patients is very rewarding kind of thing to be able to do.
Thank you, Dr. Atkins. Over to you, Dr. Shamati.
Yeah, if there are no further questions, would like to really thank Dr. Atkins for his inspiring journey and for doing so much for the patients, and still with so much of enthusiasm. It's really, really inspiring for all the young people that you never stop thinking about new things, and what you aim to achieve can be achieved based on your enthusiasm. That was a really nice talk, and thank you for being here in spite of your really, really busy schedule. We appreciate it a lot, and it has really helped our students to understand about what goes, because they all learn about the use of stem cells in their basic classes, but they have not seen any lecture thus far about what it means to have a stem cell transplantation or how it works. And so this was really a new experience for our students as well as for us. Thank you for enlightening us with all this information, and we hope to continue this interaction at some point in future. Hopefully we'll be able to invite you to India. Not virtually, but yeah. Thanks a lot, Dr. Atkins. Thank you.
thank you very much for the invitation, and thank you for listening.
Thank you. Okay, with this, we end this session and tune in for our session 2, which we will come up with an advertisement. We'll take a couple of months of break and then we'll get back to you with the new session. Thank you all for joining this evening. Bye.
Bye. Thank you again.
Thank you, Dr. Atkins. Thank you. It was a pleasure having you.
Thank you. Bye-bye.
Take care. Have a good day.